Good afternoon or good morning, everyone, wherever you are based. My name's Helena Wilcox. I'm a senior researcher at the Health Policy Partnership working with the Lung Cancer Policy Network Secretariat. And I'm so pleased to welcome everyone, our panelists and speakers, and all of you as attendees in the audience to our webinar today, focused on how health systems can optimise the implementation of lung cancer screening. Before I begin, I'd just like to give some brief housekeeping notes. Firstly, you're probably aware that the webinar today is being recorded, and so the recording will be shared on the Lung Cancer Policy Network's website within the next week or two. The chat has been disabled for participants, so please do interact with us using the Q&A box. That goes for asking any questions of our speakers or panelists, as well as if you do experience any technical issues that we might be able to support with, then please do send us a message there and the team will do their best to support you. You're also probably familiar that the webinar today is running over an hour and a half and is split into two sessions. So the first session will take us about an hour, and this is where we will have several speakers and a panel discussion featuring members of the Lung Cancer Policy Network, where we'll discuss several aspects related to our sort of key question of how health systems can optimise the implementation of LDCT lung cancer screening. We'll then move on to a short break of around 5 minutes, and then we will be sharing with you a deep dive walkthrough of the Lung Cancer Policy Network's new framework to support the implementation of LDCT lung cancer screening. And that will be more of a detailed introduction to the implementation framework, where you can learn more about how it was developed and what is included in the framework, as well as how you can apply it to your own health systems and settings. We have a fantastic array of speakers, and we're thrilled that so many of our fantastic network members have agreed to participate in the webinar today. To give our opening address, I'm very pleased to welcome Dr. Karen Kelly, who is the CEO of the International Association for the Study of Lung Cancer, who will be very kindly sharing our opening address today. So welcome, Karen, and thank you so much for joining us.
Thank you. So it's really a pleasure to be part of this webinar this morning or this afternoon. So for those of you who don't know, the Lung Cancer Policy Network is a global network that's really advocating to make lung cancer a high priority policy issue for the world. And so with that, we are really very global. We have a diverse group of partners ranging from clinicians, researchers, patients, advocates, and our industry partners. And what we do is we come together to make consensus recommendations and insights that we can then start engaging policymakers around the world in different countries so that we can give them the tools to help them make lung cancer policies a priority in their country. We have over 50 members of the Lung Cancer Policy Network, and it's really a privilege, and I'm really proud that the IASLC, the International Association for the Study of Lung Cancer, is part of this just fantastic endeavor. You can also see on this slide that we have a lot of partners there listed. Next slide. So as a thoracic medical oncologist for over 30 years, I've really spent my career trying to save the lives of my patients. But unfortunately, because my patients are diagnosed with advanced stage disease, I really haven't been very successful. And we all know that lung cancer is the #1 cause of cancer mortality worldwide. And unfortunately, it is projected that mortality rates are going to increase. But we can change that trajectory if we implement low-dose CT screening. We know it's well established, and Dr. Henschke will talk about this in a minute, that can save lives. So it's really wonderful that we already have several countries that have implemented national screening programs. For example, the United States, in Europe, the Czech Republic, Croatia, Poland. And just a few weeks ago, we found out that Australia as well will be implementing a national screening program. There are many other countries who are committed to doing that. Other countries that are doing implementation research right now with the hopes of implementing low-dose CT screening programs. So there is a lot of momentum for low-dose screening programs to be implemented. But it really does take the entire health system in order for us to accomplish this. Next slide. And that's why I'm really thrilled that the Lung Cancer Policy Network took on this endeavor to create this new framework. What I really love about the framework is that it is available to be used no matter where you might be in your journey to implement low-dose CT screening. So if you're at the beginning of this journey, you can really use this very robust framework. It really takes into account lessons learned, best practices, so that you don't have to reinvent the whole wheel when you're doing something like this. And that's really, I think, critical. But even if you're at the end or getting ready to just implement, you can use this framework as really a double check on how it's going, if you're really truly ready to go, making sure you're not missing anything because it is such a robust guideline. So as I said, you can use it wherever you are in your implementation, preparedness. And our whole goal here is to help you be successful in your program and to also run a program that is of high quality. And that's what we all want. As I said, we truly can change the trajectory of this disease with implementation of low-dose CT screening. And so I'm really excited to introduce Dr. Claudia Henschke, who's really been an icon in the field of low-dose CT screening, to give you some more information.
Thank you very much, Karen, for that introduction, and I'm glad to be part of this webinar. Next one. It's important to recognize that more than 2.2 million people were diagnosed with lung cancer in 2020, and that means 1/5 of all deaths from cancer are due to lung cancer. And lung cancer places a very high economic burden, more than other cancers in a country. This lung cancer incidence and mortality are expected to continue to be high in the coming decades. Smoking, of course, is a major risk factor, but 10 to 25% of all cancers worldwide are diagnosed in people who have never smoked, so we need to pay attention to that as well. So targeted low-dose CT screening can reduce mortality by up to 1/4, but it's important to realize that these are measures in the context of randomized clinical trials, which were very important to gain acceptance for lung cancer screening. However, what's important for the individual seeking screening, it's important to know that if I'm diagnosed with lung cancer, my cure rate, regardless of what stage or what treatment, is 80%. That's a wonderful number compared to a much lower percent that can be cured currently without screening. And if you're found in the earliest stage, when it's small, your cure rate is as high as 95%. That's really a remarkable improvement in the cure rate for lung cancer. Next. So it's important to also realize that low-dose CT screening provides information on many organs that are that are viewed in that low-dose CT. Consider it as an annual health check of your heart, of all the organs that are shown here: the thyroid, the thymus, the breast density, the liver, adrenal glands, osteoporosis, and also emphysema and bronchiectasis. So it provides a health check of all of these organs on an annual basis. Thank you very much.
Thank you so much, Dr. Henschke, for taking the time to set the scene for our webinar today and to share the importance and the role that low-dose CT screening for lung cancer can play in improving outcomes. I'm delighted to move towards our panel discussion for today. We're delighted that members of our network have kindly agreed to participate and to bring their wide-ranging expertise in research into lung cancer, as well as practical experience in implementation of screening programs from around the world. In terms of how this session will run, we have about 35 minutes, which we hope will be plenty of time for discussion. So I'll introduce all of the speakers and then invite each of them in turn to respond to an opening question around different considerations for implementation of lung cancer screening. And then we will move into a panel discussion. So if you do have any questions in the audience, then we very warmly welcome you to use the Q&A function that's located in Zoom to put your questions forward, and we'd be very delighted to bring those to the panel. And then to draw the panel discussion to a close, we'll also then ask all of our panelists to share a closing remark. So I'll introduce each of the panelists in turn first, and then I'll invite each of you to give some opening thoughts to kick off our discussion. So firstly, I'm very pleased to introduce to you Dr. Joelle Fati, who is a network member and is the Chief Healthcare Delivery Officer at the GoTo Foundation for Lung Cancer based in the US. I'm also very delighted to introduce to you Professor Stephen Lamb. Again, Stephen is a network member and he is a Professor of Respiratory Medicine at the University of British Columbia in Canada. We also are very pleased to be joined today by Edyta Żurowska, who is the Professor and Head of the Radiology Department at the University Clinical Center and Medical University of Gdansk, based in Poland. I'll move on to introduce Hilary next. Dr. Hilary Robbins is also a network member and scientist with the International Agency for Research on Cancer, based in France, but bringing an international research perspective. And we will shortly be joined by Professor David Baldwin as well, who is Honorary Professor of Medicine and Consultant Physician at the University of Nottingham, and Professor Baldwin is based in the UK. So I'll invite each panelist to provide some opening remarks to sort of kick off our discussion and share some key considerations and experience of implementation. And I think one thing that's really key, both in planning for implementation of a screening program, as well as something that really strongly underpins a robust implementation of the program, is governance. So Professor Lamb, please can I come to you first to share your thoughts on how good governance can be established for a screening program?
Yes, a good governance structure is extremely important for implementing and operating a lung cancer screening program that is efficient, equitable, and impactful. So in Canada, healthcare delivery is at the provincial level. So I'm going to give you an example how BC Cancer operates the provincial lung cancer screening program that include not only lung, but other screening program as well, such as breast, cervix, and colon. And this allows us to integrate screening programs and share resources. So our governance structure is designed to ensure all eligible individuals have an opportunity to participate in a high-quality screening program. And if the screening result is abnormal, the patient is provided with appropriate recommendation for further testing and follow-up. So BC Cancer establishes the policies, the guidelines, and also the protocols for the screening program. So we have an information network that link every aspect of the screening pathway to allow us to have the data information in real time, to allow us to send out a routine annual or biannual surveillance reminders, early recall CT, or send out a fast-track referral for abnormal screens that need a diagnostic workup. We also monitor the system performance to ensure quality assurance and quality improvement, as well as doing the outcome evaluation. So in other provinces, such as in Ontario, Ontario Health also have a similar function. So nationally, we have the Canadian Partnership Against Cancer that operate the Canadian lung screening network to facilitate knowledge sharing and knowledge exchange, and to evaluate new evidence and collect data across the country for program evaluation and improvement using national quality indicators. So this is the framework that we use in Canada for lung cancer screening.
Thank you, Professor Lam. And that leads very nicely into our next speaker, Dr. Joelle Fatty. Professor Lam mentioned guidelines and policies there, and in the US, screening has been underway for quite some time. And I wondered, given the sort of growing body, the significant body of evidence that exists around LDCT screening, but increasing evidence is becoming available, how has the US responded to this evolving evidence base through the development and updates of guidelines and policies?
Thanks, Helena. Well, first I want to applaud our Canadian neighbors. They've got a lot of great things going on that are very much more population-based and for the benefit of their entire population. And I wish that we were there in the US, but we're not quite there yet. So, the good news is that we've passed some policies here, legislation, and have sort of instituted national frameworks that include best practice standards and guidelines for lung cancer screening that are all evidence-based. One of the challenges that we have is that each of our 50 states in the US are governed a little bit differently. And so we have national standards and policies, including coverage and reimbursement standards and legislation. But when you start looking at things state to state and payer by payer, we are not a national health system. Things get a little bit more, we see more variation in how we're able to implement lung cancer screening. So the good news is we have to-date coverage and reimbursement for lung cancer screening overall. However, we even have current threats to our reimbursement policies. And so this is constantly really kind of a battle for us in the US in terms of ensuring that everyone who are eligible for lung cancer screening are indeed getting access and coverage to that screening. So we've got national guidelines and policies, but we also have implementation standards that we need to continue to strive for in our healthcare delivery systems to really kind of streamline and reduce variation and broaden our horizons around capturing everyone who's eligible.
Thank you so much, Dr. Fatty. That's a fantastic introduction to the successes, but also some of the challenges and considerations for that I'm sure will be relevant to others in different settings as well. And you touched on the sort of importance of reaching those who are at highest risk of lung cancer. And Professor Baldwin, could I come to you next to share your thoughts around targeted recruitment and also the importance of making sure that the screening program is designed in such a way to reach those who are at high risk of lung cancer, particularly thinking about where there are inequities in who that affects?
Yeah, so I think it's very important for people to understand that the cost effectiveness of screening is related to how well you select your population. It's a targeted program because we have additional risk factors which enable us to target a population that has more chance of developing the disease. And because it's a relatively expensive test that we're using, we have to do that. If it was a really cheap test that was easily applied, wouldn't have a problem, but we do. So inevitably, there's going to be some degree of inequity unless you get your selection criteria really well worked out. So there's a lot of work on this. People like Hilary and other people and Stephen have done some great work on risk prediction models to try and select the populations. But when you're starting a program out, one of the considerations we had in the UK was to say, well, what is it going to look like in a year or two's time? If we don't detect lung cancer, then everybody is going to say this is a bit of a waste of time. So the approach that we took was to go for the areas in the UK for the first set of pilot sites in the first phase that had the highest incidence and mortality for lung cancer, with the view to get the biggest amount of cost effectiveness there, really. So we wanted a good bang for our buck, as it were, and that's exactly what we got. The initial detection rate was just under 2%. Since it has gone into phase 2 and 3, where we've gone to slightly lower incidence areas, then it's dropped to about 1.5% as a baseline prevalent screen detection rate, which is pretty good. But the other thing that's absolutely amazing is that the latest figures that are coming out are showing that whereas normally speaking, lung cancer, the people in the most deprived socioeconomic groups have a lower rate of stage 1 and 2 cancers. But now we're seeing that the line is completely crossed over. So the people in the lowest socioeconomic group have now got the highest proportion of stage 1 and 2 cancers in the population for lung cancer as a whole. That's astonishing when you consider that we haven't yet reached the estimated 20% of the eligible population. We haven't yet invited or at least identified those, because not all of these people come for the screening. So even that relatively small number can make a massive difference. So I think it's really important to target the appropriate population. You can then improve and level up the disparities that you see in socioeconomic groups, as we've shown in the UK.
Thank you, Professor Baldwin. And in that, in everyone's introductions so far, I think we've heard that the screening program will require a lot of data in order to be able to target this program effectively, but also that it does generate a lot of data, which then you can use to evaluate whether the program is achieving those intended aims on population health. So with that in mind, Professor Żurowska, please, may I come to you next to ask, from your experiences in Poland, how can we successfully evaluate screening programs and make sure that they are meeting those intended aims?
To evaluate the screening program effectively, we should a lot of data, and we should focus on data quality. To collect data effectively, we need a special IT system where all the data can be stored, protected, available. Data must be gathered in a well-planned, organized manner. And we have this system. To build our platform, we benefited from Claudia Hęszke's experience, and thank you very, very much, Claudia, for your foresight. Our platform enables us to qualify participants for lung cancer screening, plan annual runs and follow-ups of low-dose CT, and to detect, characterize, and manage nodules. This workflow is represented by standardized structured reporting and is an important element of quality assurance in lung cancer screening. The type of data to be collected includes participants' epidemiological data, medical and smoking history, number, volume, size of detected nodules, invasive diagnostic procedures, number and stage of detected cancers, as well as surgical or other types of treatment. To use the collected data for future research, we always get the consent of the bioethics committee and the screening participants. To analyze scans, we use a CAT system and I, which detect and measure lung nodules volume, count the volume doubling time, and the probability of malignancy. As a result, the radiological assessment is shorter with fewer false positives. This system is an ongoing work in progress, and we learn and adapt whenever necessary to improve it. The system is also used as a training and quality control platform, as also as effective dose monitoring system. The system is also used for data monitoring, and for example, we showed that one of our centers had a higher false positive rate of lung nodules than other sites, and this is why we did the second reading of scans. This second reading showed that the radiologist needed more training. And I would like to underline that the role and way of data collection is crucial for the monitoring and evaluation of the lung cancer screening. Thank you.
Thank you so much. To sort of round off everyone's opening remarks, Dr. Robbins, please may I come to you to share your thoughts on how we can maximise the value of what we learn through implementation of screening to improve screening programmes in the future.
Hi, everyone. Thanks so much for having me. So you'll see that I'm coming at this from a research perspective and thinking about when we implement lung cancer screening, how can we collect information that facilitates future research? Much of this overlaps with the points made about monitoring and evaluation, but at times it's a bit broader. So I was going to make the same point about requesting consent from participants for use of their data and potentially samples and images for future research in a general sense. This one sort of simple step can really revolutionize the utility of your data for future research. And then you really need sort of planned, centralized, standardized data collection, preferably designed in collaboration with people who do research, population scientists or similar, who sort of know how to collect that data in a way that it will be as usable as possible. One important thing is to kind of apply uniform approaches and to really minimize missing data and to know when data is missing, what that means. That's one of the most complicated issues that we sort of deal with in research day to day. And then, of course, it's obvious that you would collect data on your screening participants, but think also about the people outside of the screening program and whether it's possible to collect information on all or a subset of people who do not participate, both people who are eligible but do not participate, to understand why, and people who are not eligible, especially in the case where it's possible to track their lung cancer incidence over time, because this can allow you to assess sort of whether your eligibility criteria are working as intended. And thinking about what aspects to cover in data collection, I won't repeat the points about, nodules and invasive procedures and lung cancer diagnoses, because this is part of monitoring and evaluation already. Although I will say that one important thing to think about is whether in the way that you collect your data, it's possible to track nodules from screen to screen. So nodule number 1 on the baseline screen, nodule number 1 on the second screen, are those the same nodule? If you put in the sort of bit of effort to make sure that you can link them from one time point to the next, then this can be quite important. But going backwards, what information do we want to collect from participants that isn't necessary for monitoring, but might be very useful for research? This relates a lot to risk factors. So we want standard information, of course, on demographics, detailed smoking information, but also think about, environmental and other risk factors, especially that might be particular to your local context. So collecting residential history can allow you to look at air pollution exposure in the past, for example, asking about secondhand smoke exposure, asking about cooking with poor ventilation, asking about occupational exposures. These can really be quite dependent on the particular context. But collecting that information allows you to look at how those risk factors relate to lung cancer diagnoses. And then also the aspects of participation. So can someone's ability to pay for screening, if that's relevant in the context, or at least their ability to travel, ability to take off work for screening, these sorts of ease of access issues, even factors related to risk perception. And then there's the kind of level 2 research aspects that you might consider. One is, of course, organized storage of the images to allow for research related to image analysis, artificial intelligence. And the other big one is collection of biospecimens. So if it's possible to collect blood specimens and bank them, store them in a good way over time, then this is something that was done in Poland very early on, which was quite remarkable because the utility of that screening data is really maximized by having the linked biospecimens.
Thank you, Dr. Robbins, and all of our panelists for sharing many different kind of aspects of considerations that need to be made when preparing for and then moving into implementing a lung cancer screening program. We've had several questions from our audience, and just a reminder to everybody that we very much welcome your questions, so please do keep them coming in the Q&A box, and we will do our very best to answer them all today. But I just wanted to kind of come back to a theme that many of our panelists mentioned in your opening remarks, which was around quality of the screening program, maybe coming from slightly different perspectives, but I think sort of making sure that the screening program is of high quality has implications for its effect on population health outcomes, how cost effective the program is. For example, Professor Baldwin, you mentioned that in your remarks. And I wondered if I could ask the panel, perhaps starting with you, Dr. Fati, around how we can robustly assess quality of the screening program and how this practice can be embedded within the program itself.
Sure. Well, I think that we need to measure the success of the program through a couple of different, from a few different angles. One is that there's plenty of evidence now that tells us what we should be aiming for, what quality really can and should look like, including thresholds for adherence. So not only getting people into health systems to get screened, but perhaps equally important, making sure that they come back for their follow-up scans. So, you know, I think that everyone should have a quality dashboard. Dr. Robbins brought up a lot of really great points in terms of what some of these quality elements should look like, but really thinking through who's getting screened, are we screening the populations in totality who are in need, who's getting to the table, who's not, how can we capture them, knowing who we're serving, but then you know, are we truly achieving what we're aiming for? Like Dr. Baldwin pointed out, you know, are the people who are in perhaps greatest need actually getting screened? Are we witnessing a stage shift? And if we're not, why aren't we? If we're not measuring it, if we're not tracking it, we won't know what our performance is. Key performance indicators are critical on a lot of lines, including when we think about the opportunities for smoking cessation in this setting. And, you know, we know that cessation can prevent the development of lung cancer, but we know that cessation can also really improve clinical outcomes. And so are we serving this population by bringing them the opportunity to achieve successful cessation anywhere across the lung cancer screening and care continuum? So there, you know, without taking up time from all of my other colleagues, there are many different quality indicators that we can embed within our programs, but most importantly, our healthcare systems need to be prepared to collect that data in a meaningful way. And to Dr. Robbins' point, you know, you don't want to just collect anything and everything. You want to be very intentional and thoughtful about what you're collecting so that you can be assured that you're going to secure the information that you need to improve your programs and drive, you know, our bottom line, which is saving lives from
Thank you so much. I wondered if our other panelists, perhaps maybe David or Hilary, Stephen, I'll come to you first.
Yeah, so the ISLC Early Detection Committee has a working group to look at quality indicators. So for example, what is the early recall rate for abnormal screen? If you refer someone for diagnostic workup, what is the positive predictive value of your recommendation? And what is the benign resection rate? So these are some of the important things to address, to look at the screening program. I think what is even more exciting is the work done by the American Cancer Society Roundtable, and also we use the same thing in British Columbia, is geospatial mapping. We can actually look at lung cancer incidence down to the community level to look at how many lung cancers are in that region, how does the staging shift with screening with time, and also in due course changes in lung cancer mortality. So these are exciting work that we need to do to look at how effective our lung cancer screening programs are.
Thank you. I wondered if Hilary or David, you wanted to comment on that at all? No, we can move on to, I mean, there's lots of questions, so we're definitely not going to be short on things to discuss. I think something that we haven't actually touched upon yet, but I think will be of interest to many people, is the sort of capacity of the health system when planning to adopt screening and implement screening when you're kind of in the planning stages. And screening is going to require workforce to be available, and also some of the technical infrastructure to be available. And at a time where many health systems are under many constraints, it's important to think about that from an early stage so that can be planned for appropriately. David, I wondered if I could come to you first, perhaps, to understand some of the approaches that have been taken in England of how to manage that capacity and enable the implementation of the screening programme.
Yeah, so this is a really difficult problem for many countries because even before you add an extra burden on the system, many healthcare systems are already overburdened. So it's going to be competing with other health interventions, undoubtedly. And it's really a question of choosing how you apportion the various amount of money that you have each year to spend on health between different interventions. And my view on this is it's best to use the evidence base that you have to prioritize those interventions that have a good evidence base. And we do have a good evidence base for lung cancer screening. We do an awful lot in radiology and other specialties which hasn't got an evidence base, and we don't really know it works at all. So there's two things there that you need to consider. One is that when you're doing a screening program, you need to make sure that you focus on maximizing the benefits through using your personnel and diagnostic capacity efficiently. So trying not to do the things that don't have benefit. Incidental findings and investigating incidental findings, for example, is often overdone. It adds a lot of cost and probably harms the patients overall. So you have to have a really good incidental findings protocol. And then in terms of radiology reporting the actual CT scan, there's a good deal of skepticism about whether this is possible in the capacity is there. But in the very overstretched NHS, we have managed so far to understand that there is capacity there. You have to manage it very efficiently, but it's amazing just how much it can step up to the challenge. One of the things that we've found is that it is better to have consortia of radiologists working together on a platform that's easy and they can access at any time. There's bespoke funding for that activity, which tends to mean that other less well-funded activities will be not prioritized. But it is causing us to, in some units, to have a really very rapid reporting turnaround time. And also you have the chance then to also apply the various protocols that mean that the recommendations from the imaging don't then cause a whole lot of downstream work. And then beyond that, what we would do to try and again improve the efficiency of the way we use the capacity is to have the screening review meetings where every flagged abnormality is reviewed, and with the objective of making sure that you're following the protocols, that you're not overdoing things, but then again, you're also not underdoing things. So where you have benefit or likely benefit, then you act immediately. When there is actually very little evidence for benefit, you either ignore the finding completely, or you at least just return to annual screening. And we all have these protocols. There's lots of evidence out there showing just how inefficient people can be, or how efficient people can be, and it's related to this capacity issue. You know, the more noise in the program, the less capacity. And there's one other thing. David Jankelevich has made a very good point, as usual, saying is, do you think that radiologists have any sort of enthusiasm to take on this extra work? Well, that's interesting, because certainly I'm not a radiologist, but I've certainly noted quite a lot of enthusiasm to tackle this problem, actually. And of course, when you have a 2% cancer detection rate, and it's interesting that the ILCAP initial report was 2.7% baseline detection rate. So it was obviously a worthwhile intervention, and I think radiologists can see this. They report enough scans to detect the cancer every now and then, and it's early stage usually, and it feels satisfying. And then the other aspect, just to finish it off, and it'd be interesting to see what people think, is the concept of a little bit of elitism here. In the colonoscopy world in the UK, you have to be specially accredited to be a screening colonoscopist. And what I'm wondering about is how we try to get this sort of elite level of radiologists that are really good screening reporters, because that could be another incentive to keep things going. Anyway, just an idea.
Thank you. Do any of our other panelists maybe have thoughts on David's suggestion, or kind of more thoughts on the broader question around managing some of those potential capacity challenges that maybe different health systems are experiencing or potentially may come across during implementation?
Well, I would say that lung cancer screening is very resource intensive, and including funding. And it's really important to have all stakeholders at the table from the get-go to ensure that there's alignment, but also reducing variation and improving standardization in how we implement the evidence and the practice guidelines to ensure that people are getting the rounded care that they need. But it's a team-based approach, and we also need to train our workforce. We need quality healthcare providers, to Dr. Baldwin's point around expert radiologists who understand the intricacies of lung cancer screening, and including the value of reporting every nodule of concern, so that we can track each nodule screen to screen. But it takes coordination and resources and commitment, and really kind of rolling out training so that people can get the right training, and we can reduce that variation that changes the product that we're able to provide to our patients in that healthcare delivery system.
Thank you very much. If the panel are happy to move on to a slightly different topic, this is something that many of you have briefly touched on around smoking cessation. As was mentioned in some of the introductory remarks, smoking, as we know, is a significant risk factor for lung cancer, and considering the sort of potential options for integration of smoking cessation within the screening program, and how that can be managed in different settings. Don't know who might like to join in on that question first, from different perspectives. Dr. Fathi, please go ahead.
Sure. I spent a lot of time in sort of that tobacco space, and ran a program with fully integrated tobacco cessation services. Again, a fully integrated program can be expensive, and really to date, we haven't fully understood how best to integrate cessation into the screening environment. You may be aware that the NCI has a number of researchers who have been investigating exactly this with the 3CI, I'm sorry, not 3CI, but the SCALE Collaborative. So very soon, I think we'll have, probably this year, a number of those researchers will be resulting their research, and hopefully we'll have a better understanding of what success looks like in terms of how we integrate cessation across the lung cancer screening environment. I don't think that it's a question if we should do it, it's how we should do it. Everyone certainly has something to benefit from reduction in tobacco consumption, and certainly successful cessation. How we start that conversation, how we get our patients to the table and engaged on that topic is a whole nother ballgame. It's difficult to approach that, and again, we need resources and pharmacotherapeutics and access to medication and counseling, which is, at least in the US, a whole nother issue to get people the resources that they need. There's just not enough of them out there.
Thank you. Professor Baldwin, you look like you might want to add something there.
Yeah, I probably should mention the trial that's been led from Nottingham, in fact, by one of my colleagues, called the Yorkshire Enhanced Stop Smoking trial, which was presented at the World Lung Cancer Conference last year. And it showed that when you co-locate, in other words, have the smoking cessation practitioner and all of the pharmacotherapy in the screening centre or on the mobile van, as it was in the Yorkshire screening trial, then at a 1 year confirmed 7-day confirmed quit rate for smoking is 30%. And the purpose of the trial was actually to present different levels of information to the different groups of people, but didn't show any difference actually, whether you showed them their scans showing lots of emphysema and coronary artery calcification or not. There's very little difference. But what it did have is a 30% 1 year quit rate. That is really high. And there's another study that's published out of London that's shown that even immediate telephone advice and follow-up produces a very healthy quit rate. So we think now that it's unethical not to embed the smoking cessation in the program, and I'm glad to say that what I do is I argue with the National Screening Committee and various other people for this change in policy, because the smoking cessation service in the UK are funded separately, and they're very variable in the way they're funded. And they're saying, well, why do we need to change that? The smoking cessation service is there, but they're just not as good. And actually, by embedding it in the program, you're going to get a much better quit rate. And therefore, that is now it's now been involved. The capacity planning and the financial planning has included that co-located smoking cessation intervention. So that's what we're doing, because we feel we've got the evidence from a UK population study which has shown it on 2 different methods. It's just a question of which method is chosen, and that's going to be largely on the basis of the cost effectiveness calculations.
I would just add, which was nicely demonstrated by Dr. Baldwin, that smoking cessation, for some reason, from where I'm sitting, seems to be one of the areas with the highest level of disparity across countries and the degree to which they understand what they need to do and how to do it. The UK has really pushed this forward from early on, and also in the context of doing research to really understand how to do it best and how to situate it within screening programs. So I think, this is perhaps an area where we need to build better bridges. And I would just, perhaps encourage people who are launching, implementing in new settings to reach out to those who have experience with smoking cessation programs, because it's not, I don't think it's rocket science per se, but I find that, many people are not quite sure where to start. But in fact, the experience is there. It's often it's highly concentrated in very particular places.
Thank you. I think that unfortunately, because there's still many open questions in the Q&A, probably brings this panel discussion to a close. But thank you, everybody. Well, firstly, thank you to all of the panelists for sharing your thoughts. I'll ask you to share some brief closing remarks in a moment. but also just wanted to very much thank all of the audience who have shared your questions, and to reassure you we will save your questions and find another format in which we can respond to you and share more of the expertise and experience of our network members. Just to kind of draw this to a close, and with time, I'd kindly ask for slightly briefer comments than maybe we'd planned, but I'd like to come to each of you in turn and ask each of you to share sort of your one key recommendation from your experience for those people working in countries where they're planning for implementation. Perhaps I could start with you, Joelle, if that's okay.
Sure. I think that we can't do this alone. It's all about partnership and securing the resources and really adhering to the evidence to roll out excellent programs.
Thank you. Thank you so much. Professor Lam.
Yeah, for the most important thing I see is to have a checklist, because lung cancer screening is not a test, it is a process. So we need to make sure we have everything thought out before we implement the program, from how we outreach to the community, how to assess the risk for screening, have the infrastructure and the expertise to read the screening CT, the respirologists and surgeons to do the diagnostic workup and treatment. So I think the latter is often neglected. We worry about uptake. In actual fact, in Canada, we actually don't have a problem in uptake. I think we see the need to train more radiologists, surgeons and respirologists to do the diagnostic workup for these very small early lung cancers. It's actually very challenging. So I think this is one area of need that we need to address.
Thank you very much. Professor Żurowska, please may I come to you next?
My top recommendations would be to firstly start with a pilot of lung cancer screening and use an implementation framework and other guidelines for pilot planning. It is also important to make use of the pilot initiation at local centers where the healthcare is well organized and has a sufficient supply of medical staff and provisions. And last but not least, I would like to suggest that it is necessary to define the strengths and weaknesses of the country's healthcare system before and during the realization of the pilot screening program, and to propose an immediate implementation of improvements wherever needed. Thank you.
Thank you. Dr. Robbins, perhaps I can come to you next. I'm working my way around the screen.
I had the pleasure of meeting Dr. Żurowska a couple of weeks ago, and she warned me that we were going to make the same point, which was to run a pilot program. So I will just add that within that pilot program, try to have a few sites that cover whatever aspects of diversity are relevant in your setting. So whether this is urban, rural, whether this is high and low resource, whether it's different ethnic groups that need to be covered, whether it's linguistic diversity within your setting, try to build that into the pilot so you can understand how those aspects of diversity need to be accounted for in the broader program.
Thank you. And finally, Professor Baldwin, for your closing thoughts. Thank you.
So I think it's all very important, actually. But I think the one other thing that one does need is to have a group of people that are making sure that the screening program aligns with the general strategy for cancer in the country, I think, and where they and ensure that they can understand how it fits, because lung cancer is a really big problem and it can always fit into a strategy. It's just getting that into the hearts and minds of the people that then make the decisions about expansions of pilots, etc. So I think it's really very important as well, because I see a lot of I give advice to a lot of different countries where it's the fiscal issues, the finances from the government, and the government's belief and unwillingness to do things, which is the principal barrier to the problem.
Thank you. Thank you so much to our panel. Apologies, I've taken us a few minutes over planned, but thank you so much for sharing your fantastic expertise from different settings and different backgrounds that you bring. I'm very pleased to now welcome Ebba Hallesjöhult from Vision Zero Cancer, who's based in Sweden. And I think David's final remarks brings us very nicely to Ebba, who is going to kindly share her perspective of the value of screening from a policy perspective. So thank you so much for joining us, Ebba.
So, thank you very much, and thank you very much the fellow panelists and experts in this meeting. And I'm following this exciting discussion, and I think everything that you mentioned we could actually put together with the mix for what's going on also in a country like Sweden when it comes to the importance and the value of thinking of a framework from a policy perspective and how to get going for the lung cancer screening. So in Sweden, we have a population about 10 million people. It's a decentralized healthcare system with publicly funded. We are organized in 21 healthcare regions. And when it comes to cancer, we've had a national cancer strategy or like a cancer control plan for a bit more than a decade. So lung cancer and lung cancer early detection, the discussion for screening, the diagnosis and treatment is part, of course, and it fits within the strategy. We are organized in knowledge management center called Confederation of Regional Cancer Centers, 6 of them. So these are like sort of the underlying conditions for the discussion of implementing lung cancer screening in Sweden. So lung cancer is the most common cause of death, cancer-related death among both men and women combined in Sweden. And the prognosis for lung cancer has improved during the last decade, of course, due to the advanced diagnosis and treatment methods. But despite this, still the 5-year survival rate is far from where we would like it to be. It's around 24% for men and 31% for women. We know this is slightly above European average. Every year, about 4,200 people are diagnosed in Sweden with lung cancer. And between 2009 and 2018, the number of cases is increased with 19%, of which the increase among women was 26%. We also see the growing number of never smokers detected also in lung cancer, and that also affects the discussion from the political perspective of the implementation of a targeted screening program for the high-risk population. In Sweden, there are currently national cancer screening programs for breast, cervical, and colorectal cancer. And during several years now, we've had the discussions and bringing together the evidence that might lead them to action when it comes to implementing lung cancer screening. According to the National Board of Health and Welfare, which is the responsible agency for setting recommendations that the regions have to implement, more knowledge is required before a lung cancer screening program can be considered. They identified several years ago the uncertainties regarding the detection of the high-risk people, such as the smokers then, as well as how to reach this group, but also, as was pointed out here before, the capacity challenge, the health economic, the cost effectiveness ratio. So this with, of course, tying it to how well you select the population, as pointed out in the panel by Dr. Baldwin. So we have tried then to bring all the stakeholders to the table to advance the knowledge needed, in addition to the medical evidence already shown through several pilots, among others, of course, the NLST and the Nelson trial. So for our authorities and politicians in Sweden, the medical evidence has been there. And is more related to the questions around the political will of financing, the capacity, how to reach the target population, how to integrate with a smoking cessation program, and also what to do with the ever-increasing never smokers that needs to be detected as well. Bringing all the stakeholders to the table has meant that with advocacy and informed discussions and knowledge from the civil society through the Lung Cancer Patient Association, the work here in the Lung Cancer Policy Network, international experience exchanges, and then working together with the Swedish Lung Cancer Study Group, which is composed of the leading researchers and clinicians in the field of lung cancer from a radiologist, also in pulmonary medicine, and treating oncologists and radiotherapists and so forth. This group has, of course, brought a lot of attention and the evidence to the table for the authorities to bring about the decision for an implementation program. Of course, in Europe now we have new recommendations for cancer screening, where member states then are invited to explore the feasibility and effectiveness of the low-dose CT to screen high-risk individuals, and that is, of course, pushing also for a momentum for our political decision in our country. We have strived to develop some pieces of evidence important to inform the discussion and also to take action. So the value of lung cancer screening from a health economics perspective has been undertaken, and with very promising numbers for the effects of a potential national screening program showing the health economic benefit ratio for our country. And it was calculations done by the Swedish Institute for Health Economics that have examined the potential effects of a national screening program. So those pieces of the puzzle have been brought to the table. And we've also conducted opinion polls, actually, with the among smokers and former smokers, from Swedish speakers and foreign speaking population in Sweden. And the overwhelming results are that 9 out of 10 smokers and ex-smokers are positive to participate in lung cancer screening. And in further more detailed questions to these opinion polls, also very keen to get the information and invitation through visiting the GP, through the health center, and also through other existing screening programs. Our first pilot is underway, and it shows very encouraging results. So right now the discussion is ongoing on actually advancing the recommendations for the implementation of a national program with smoking cessation. So a pilot project was implemented in the Stockholm region, which is our largest healthcare region, in this autumn. And targeting one group, which the women, so that we could, through the selection database for the mammography invitations, send in letters to with the questions to find out more about the smoking status and the interest to participate. And through that database, been able to send invitations for screening. And it's planned that for 2 years to screen about 1,000 women. So far, up to date, 336 individuals, according to data from last week, have been screened. We see a detection rate of about between 3 to 4%. 12 have already been diagnosed, and also using AI programs. So they are also from the beginning using AI to screen and for the diagnostics, and some have already been treated. So very promising results. And also we also seen that the target population are attending in respect to what was anticipated in the numbers of who would actually accept the invitation for screening.
Thank you, Anna. That's fantastic to hear. I'm so sorry to rush you, but perhaps I could ask you to sort of conclude your thoughts on screening in Sweden. Thank you.
Yes. Thank you so much, Helena. Yes, so to conclude, just as was highlighted before, it's very important to have a pilot, one or several in a country to calibrate and test your capacities, but also then align on the overall strategies of a cancer strategy, and making sure that you get the different pieces in place. We see also, and I think was very much highlighted in the panel before, that lung cancer is not a test, the screening, it's a process. So the different pieces have to fit together. And the framework is a very good tool to build on that, to make sure that you get all the pieces there, from how you actually select the population to the cost effectiveness and the whole planning of the capacity. And we are aligning this with the research and also making sure that we can benefit from future research to implement screening.
Thank you so much. It's fantastic to hear the progress and the process that Sweden is taking, and look forward to hearing more as that develops further. Thank you so much for those who are still with us a few minutes late, which is solely down to my timekeeping. But I'm delighted to welcome back Dr. Karen Kelly, who will share our closing remarks. And just before I introduce Dr. Kelly again, just a reminder that in a couple of minutes following Dr. Kelly's remarks, we will be walking through a walkthrough of the implementation framework. So if you would like to stay around following Dr. Kelly's remarks, then we would very much welcome you to. So please, Dr. Kelly, we look forward to hearing your reflections on today's session.
Well, first of all, let me say that just a wonderful panel, a wonderful discussion. And I think my first take-home message here is that you can see from the panel that this is a global panel, and that we really need to continue this dialogue among all of us. I think that this really is the path forward, learning from each other. I think that you see that we're all very passionate about this issue, and together we can make this successful worldwide. We've heard a lot about the challenges of CT screening, but we've also heard a lot about the successes. And I would say that the lessons that I've learned, yes, this is a process, and we have to go beyond the health system. I think that that is step one, in being very prescriptive in the preparedness, the readiness of looking at each and every aspect, making sure that we have all the stakeholders, not the traditional stakeholders only. Of course, it's the patients. Of course, it's the doctors. Of course, it's the actual health system. But beyond that, the economists that can really help show that cost effectiveness, the governmental, our governmental colleagues. I think we need to bring all these people together earlier rather than later. And of course, we know that we have to have high quality, that once we implement a program, I would love the pilot program approach, because you implement and you learn as you go. You've got to continue to monitor, to continue to enhance, continue to really break down the barriers. We heard a lot about access, disparities, learning from that, as well as research. The research component, we have a lot to learn here from many different research dimensions, from just access alone, patients' needs. We heard about disparities. How do we overcome those with implementation, more implementation research, the cost effectiveness, the training, and making sure that the data can be utilized in a standardized way. So I think it's really just so exciting, but yet I understand that we still have a lot to do. But we can do this, and we can do this if we work together. And so that's my real take-home message. And I just want to applaud all of the speakers one more time for really raising some really, really important questions. But we can answer these questions. We can overcome this. So I'm going to leave with that closing remarks.
Thank you so much, Dr. Kelly, for your opening and closing remarks. And I think that's a apt reflection on the role that collaboration can play in advancing implementation of LDCT lung cancer screening. So with that, I'd like to thank everyone who stayed past the hour and thank all of our panelists and all of our speakers today for joining.